closely with two other gals in the office, Julia and Ashley. Julia's been with him for about 6 months. Ashley's been with him for about 3 years, and I've been with him for about 150 days or so. But he's a great guy to work for and work with. So I'll walk you through what a week in our office kind of looks like for our team. Monday mornings he does his surgery procedures either at our surgery center upstairs in our Flower Mound office, which is a real convenience for us and our physicians here at Orthopedic Associates. And then he comes downstairs and we see a few patients in the afternoon on Mondays. Tuesdays is our full day of clinic, so we are seeing patients 8 a.m. to 4 p.m., about 4:30 sometimes even. Let's see, Wednesdays we do half day, so in the morning we're in clinic, and afternoon I'm at my desk typing away, preparing for the next week. The next day, Thursday, today, I'm normally at my cubicle all day, prepping charts for next week and getting any surgical things in order for him for the next week. Friday mornings, we are in our North Lake office. As I said, all of our physicians do spend one day there at that location, which is pretty close to you guys over here. And then Friday afternoons, we are back in our Flower Mound office again. So that's kind of what a week of Dr. Cantrell's surgery schedule looks like, and that's what we get to do. Working with him, and it's a real pleasure. I can't say enough praises about him. He's been with Orthopedic Associates. I want to say this will be his 30th year. I believe he started with them in 1994. And I heard that you guys were expecting this presentation on aching joints. Is that correct? Yes. Alrighty, so show of hands here. Who was here coming interested for shoulder joints? Raise of hands. A couple, a familiar face here and there I'm seeing in the crowd too. Let's see, knees, how about knees? The bees and knees, lots of knees, okay. Okay, ankle, who is excited about the ankle talk today? We've got a few, I'd like to see it. Any other hands want to be raised? Anything you were curious about to know in today's talk? Neuropathy, that's a big one too, the numbness and tingling, I can't imagine. Hips as well, that's a good one. Yep, we do have a few physicians in our office that would do the knee and hip replacements. Anything else? Plantar fasciitis, is that what you had said? We'll be talking about that in today's talk here too. Well, lower back, okay, yep. We just had a physician who was with Orthopedic Associates for 35 years, Dr. Giesler. He retired this January. So we had the pleasure of working alongside him for that long period of time, and now our physician, Dr. McElroy, is taking on his own patients in addition to Dr. Giesler's patients. So we're looking around, scouting the area possibly for another spine guy to join the practice. Any questions anybody had while I'm up here? I'm open to seeing if I can answer anything from anybody here. No questions. Pretty good. Pretty good. Yeah, new patients can get in, I would say, in a week's time frame. Like I was saying, on Thursdays, we prep our charts for the next week. So on a Thursday, on Monday to Friday, the next week is fully booked. New patients can expect to get in around a week and a half. And Dr. Cantrell takes care of each and every one of his patients with empathy and compassion. And if there's somebody that needs to be seen quickly, he is more than happy to work them in according to his schedule. He's really good about that. Like Joyce was sharing, he is the physician for Argyle High School, so we do see a lot of those kids coming through playing football, tennis, any kind of sport that Argyle offers. Anybody got grandkids at Argyle High School? A few, love to see it. Alrighty, anybody, any more questions you've got for me here? Yes, ma'am.
Does anyone do orthotics in your organizations?
Orthotics, we do have a foot guy, Dr. Willenborg. He does do custom orthotics in the office, so if you'd like to see him, give our office a ring. Anybody else? Yes, ma'am. Back here.
How many physicians do you have?
Minus Dr. Giesler retiring this January, we have 10 other physicians in the office. Yes, ma'am. Sciatica, I believe that would be Dr. McElroy, our spine specialist. You can see him for those kind of issues. Yes, ma'am. Anybody else? Any questions at all? Sounds great. Alrighty, y'all. I'm going to shoot his text, see where he's at the moment. Pray for him. He's got the other assistant, Julia, driving him over here, so hopefully making in record time. Thank you guys for your patience.
I'll take
Really
this question.
appreciate it.
Y'all hear me okay?
Yes.
So, I understand that my topic was foot and ankle, but I'll stay here afterwards. We'll start talking about anything you want to talk about. Knees, shoulders, elbows, whatever you want to do. So, all right, y'all ready to get going? So,
It's going. It's going.
all right, how's that? All right, so let's get started, foot and ankle. We'll go through this fairly quickly. How does it? Oh, there we go. There you go. So, when y'all met Julia, I'm sorry, met Peyton. Julia just dropped me off. So, all right, so just quick outline what we're going to what we're going to talk about as far as foot and ankle. Go through some anatomy, mechanics, injuries, non-injuries, and treatment, just real quickly. Okay, so just as a way of introduction, I'm sure a lot of y'all, I see a lot of familiar faces. Orthopedic Associates, we have our flagship in Flower Mound. We now have out here by Harvest in North Lake, we have our satellite. We've been in existence since 1976. We're all proud of that. We've got 10 physicians now. There used to be 11. Dr. Giesler just retired. I didn't mean to go backwards, but so I always like to kind of get to know my audience and have my audience know me. So I'm local. Graduated from Louisville High School in '79, went on down to A&M for pre-med. And then UTMB in Galveston was there 10 years for both residency and medical school. And came back to Dallas and did a shoulder fellowship at Carroll Clinic at Baylor University. And I'm proud to say I'm going on 30 years being here. So next slide. So these are my first grandkids, Scovia, and thanks. Sorry. It's been a long day, no more. All right. So this is Pepper and Teddy. We'll go through this. They keep me young. So next slide. So just getting to know y'all. Is there anyone who's had ankle surgery or ankle surgery or injury? Okay. How about anybody? Any other orthopedic injury or surgery? So you got a plaque on the wall there. All right, so quite a bit. All right, any athletes in the room? Assume most of y'all are, because this is a pretty athletic population. All right, so any medical professions? I just learned that this is M&M, and so you don't have to stand up. But any medical professionals? Okay, physical therapists, anything? I don't want to insult your intelligence, so if I get too basic with the anatomy, just wave at me. So, all right, so everybody loves anatomy. We'll go through it pretty quick. I included those slides just to kind of show how complex the foot and ankle is. Lots of ligaments. We'll go through those. So if you look at the bones, you've got the toes, which is the phalanges. You've got the midfoot, which is the metatarsals, and then you have the hind foot, which is mainly the calcaneus and the talus. Next. So I'm not going to go belabor this point about the ligaments of the ankle, but I do want to just share these. You've heard a high ankle sprain versus a low ankle sprain, or regular ankle sprain. So pay attention to these ligaments here, the syndesmosis of these ligaments there, and then versus that's a high ankle sprain versus the classic ankle sprain. Go the other way. So this slide just shows how complex all the ligaments are in the foot. Even though if you don't break anything, it certainly can hurt. Next one. So tendons of the foot and ankle, there's a ton of them. They either bend your foot and ankle backwards, downwards, or to either side. So the point of showing you all these is that it doesn't, you don't have to fracture something or have a big rough injury to have some pain or injury to the foot and ankle. Okay, so she's here so I can tell this story. So next slide. So y'all remember the cold snap about 2 weeks ago or so? Everybody dripping their faucets, wrapping their pipes. So we did all that. Insulated our house, did all that. Well, I've been working inside and out, and we're sitting down and watch the last playoff game of that particular weekend. My wife comes in and says, her actual words were, "There's water running on the floor." And I'm like, how can that be? We've done all the right things. So she says, "There's water running on the floor." So I ran in there thinking, what's going to happen? What am I going to do? So I turned the corner, and what did I see? So... At first I really didn't think it was that funny, but I laughed so hard as there was no water on the floor. All right, so it's exploring the basics. So a lot of this is going to be the function of the foot, which is what we're here to talk about. All these components play a role. Bones, of course, for stability, but the key two things are weight bearing. Not only standing, but moving. That's propulsion. Shock absorption, anytime you get out of a chair, out of your car, that's important. We want to talk a lot about neurologic control. I heard somebody mention they want to talk about some neuritis and things of that nature. But coordination and sensory feedback are so important. If you don't have fingering or if you don't have balance, it can affect your whole body. So this is a slide I included just to talk about how important the foot is in the overall gait. There's been a lot of doctors that have made physicians, PhDs, a lot of people that have made a whole career out of studying the gait. But the point of this slide is as you can see, if something's going wrong with either foot, it's going to affect the knee, the hip, the back, even the trunk. So, all right. If this was me, I'd be sunburned. All right, so common foot and ankle injuries. We're kind of getting close to the end of the foot and ankle things. We can kind of break them down into common and least common. Sprains and strains. I'm sure everybody knows the difference between a sprain and a strain. Typically, a sprain is involved in ligaments. Remember, I showed you all those ligaments before. And what's a strain? More of a musculo-tendinous junction. Muscle tendon, where the tendon attaches to bone. That complex. So we talked about the classic high ankle sprain, or classic ankle sprain, which is everybody rolls their foot, versus a lot of athletes get the high ankle sprain, which is a poor prognosis. So a few foot fractures. Calcaneus fracture, upper left, is a hindfoot fracture. The navicular stress fracture is a midfoot fracture. And then forefoot fracture, you see the fifth metatarsal on the bottom left, right to the, keep going, coming towards me, down. And then the phalanx fracture, which is a toe. So, all right, next slide. So we talked about the ankle tears and sprains. These are the most common ones here. And then the Achilles, I'm sure there's probably somebody in the room that's had an Achilles injury. It's very common. The reason is, if you look how strong the muscle is up top, it's basically the muscles that create that, and then a very long tendon. So there's a watershed area. Some of the blood supply comes from the calcaneus or the heel. The rest comes from the muscle. There's a watershed area in between where, just like if your water pressure on your sprinklers is not too good, there's going to be two zones aren't going to connect. So you'll have some brown areas. You'll have an avascular area which will be more prone to tearing. So ankle fracture is a little bit higher up. On upper left is the inside funny bone, medial malleolus. The bottom right is the outside funny bone, which is a fibula. And then ankle fractures a little bit more complex, including the talus and the whole ankle joint. Yeah, I know my toes have burned many times. Next slide. So degenerative disorders. It could be any of us over 40, anybody that's been active. Anybody in the room have plantar fasciitis or heel pain? Yeah, it is not fun. Everybody goes to the doctor, they get an x-ray and see a heel spur there. That's what's causing pain. What's not causing the pain, what it is the plantar fascia is very tight, and it connects to the heel. That's what makes a spur. But the spur in and of itself is not the pain. I don't know if y'all can see back there. There's a tiny little nerve that wraps around right underneath that plantar fascia, and that's what really gives you the pain. So the key thing is most to be treated non-operatively. Bunions, very common, mostly from shoe wear. So there's also a tailor's bunion, which is in the bottom left, which involves the little toe. Next slide. So this is a lot of people that have been active all their life have been wearing tight shoes, pointed shoes, can have claw toes, mallet toes, hammer toes, curly toes. They all look about the same, but as you can see, it depends on what position your actual toe bones are in. These are some examples. The hammer toe is on the left. This is actually the mallet toe, hammer toe, mallet toe there.
What makes it a mallet?
So it's the joint at the end versus the hammer, which is a joint back behind. It's usually shoe wear, stubbing your toe when you're younger, don't even realize it. So kind of getting close to the end, degenerative arthritis or any other degeneration to the ankle or foot. You can kind of see the x-rays, normal on the left and on the right degenerative. The first toe has a lot of arthritis in it. It's common. I did laugh the first time I saw it. So most of the time we can take care of degenerative or any kind of foot and ankle disorder non-operatively. Whether it's simply getting on crutches, elevating it, doing some physical therapy, modifying activity, medication. We have all kinds of other options: casting, walking boot, injections. We now have laser therapy, robotic laser therapy. So the majority of times, even though we're surgeons, we can treat things non-operatively. Operative treatment, I won't go into too many details, we spend the whole weekend talking about it, but very simply, starts off as repairing, replacing, realigning, or reconstructing, and then in the case of fractures, reducing. So the 5 R's are fixing it. So just a brief, this is a good joke to lead me into the next slide. Our group is orthopedic surgeons, and we have a lot of colleagues and friends that are podiatrists, but just want to show you the difference. The orthopedic guys do 4 years of pre-med and then 4 years of medical school, and all of us do 5 years of residency, and then almost everybody now subspecializes and does a year fellowship. Hand, in my case, shoulder. We have foot and ankle specialists, spine specialists, joint specialists. So, all right, next slide. That's it. I mean, the 49ers are going to win.
49ers!
I just think they're too strong. I like Mahomes, but I think, all right, I think we're at the end of the foot stuff.
So we had a little party at Orthopedic Associates for Halloween, and the foot guy, Dr. Willenborg, one of his assistants, made this little snack for us. It's made out of cream cheese and prosciutto, and I just thought it was pretty funny to include on it.
Even knowing what it is, I don't know if I could eat it.
While she's looking for another talk, shoulders or whatever, anybody have any questions about what we went through so far? Yes, sir.
What's your opinion of gabapentin for neuropathy?
I love gabapentin for a lot of pain now.
And orthopedic, into shoe insert help the foot if you've got neuropathy?
Quite a bit. My foot and ankle specialist, Dr. Gilmore, who's tied up, he does that a lot. He's got a relationship with a lot of orthotists that are around the area. That's a big starting point for a lot of things for him. Good question. Yes, ma'am.
Doctor, you need to repeat the question and then answer it.
Okay. You're right, I should know that. So his question was, number one, what do I think about gabapentin for diabetic neuropathy or other neuropathy and for pain? And my answer, what you probably heard it, was that as orthopedists, we do use gabapentin for neuropathy, but also for post-operative pain management. As we're trying to phase out of narcotics, it's become a very good tool in our tool belt. His second question was about, does our group recommend inserts or orthotics for the shoes? And as you may have heard, our foot and ankle specialist has a good relationship with a lot of the orthotists, the shoe salesmen around the area, so he does a lot of that. We have over-the-counter and off-the-shelf inserts that you can get from our office as well, but he also has custom that he can get made.
Can you non-surgically repair plateau, whatever the toes look like? Can you do that?
That's a good question. So she asked if you could non-operatively treat a hammer toe, mallet toe, any of those. The short answer is yes, depending upon how far along it is. If it's still flexible, if the x-rays look good, then a lot of times you can do some therapy, maybe adjust your shoe wear, change the sole of your shoe. So,
Not operatively.
I'll get one in the back.
Is there any treatment or any new treatment to regain your gait if you've already gotten into a shuffle?
You mean as far as like a Parkinson's shuffle or something, neurology?
Just the old man shuffle.
So, I'm told I'm there as well. So, short answer is yes. Physical therapy is a good mainstay. We can evaluate your footwear that you have. Sometimes you have some tightness around your hip, tightness around your Achilles, and a lot of times we start off, if everything x-ray-wise looks good, then we can get into therapy and stretch all those other areas. I'm sorry, say that again. The question was metatarsalgia, which is basically a lot of the pain on the ball of the foot. Exercises can help, because a lot of times that's caused by tight tendons, tight fascia, but usually in addition to that, shoe wear is key. Inserts that were over-the-counter or custom. There's so many good shoes out there now. A lot of you probably had them. Brooks, Hoka's, what I wear in the operating room and things. So. Yes, ma'am.
What about the need for dental clearance before you have surgery? Dental clearance.
Oh, that's a really good question. So, yes, typically all patients will have to have medical clearance. Now, sometimes patients are in our office, we deem that they're good health, no heart issues, no prior strokes or anything like that, so we can chat with our anesthesiologist and they're comfortable not getting medical clearance. For some of the bigger procedures, we either have them go to a primary care doctor or a cardiologist, for example, and get EKGs, x-rays, whatever they need to do. A lot of the hospitals now will do that, kind of streamline the process for you. But a lot of patients that have even relatively straightforward surgery, because of the anesthesia risk, we do get medical clearance.
I didn't hear that question.
But the question was, sorry, the question was, do you need to get medical clearance before having any kind of orthopedic surgery or foot surgery? And the answer is, it depends upon your general health. Any cardiovascular risks, we do. Yes, ma'am.
The dental clearance of teeth, is that really important?
Good question. She asked if dental clearance is important. For any, and we'll talk later about some of this if you have a question, but any time we're going to replace a joint, artificial shoulder, knee, things of that nature, there's got to be good dentition. No cavities or any things of that nature, both preoperatively and postoperatively. So we do work hand in hand with that. I had a cancel patient a couple of weeks ago. I was going to do a total shoulder, and she had a toothache and just had to go to the doctor, and we had to postpone her.
And why is that?
So the mouth has a lot of she asked, why is that? Why do we have to get that dental clearance. So the mouth is colonized with good bacteria to help with digestion things. And if you stimulate that with a dental procedure, then that gets in the bloodstream, and the place it's going to go is a metal artificial surface. It's going to, without going into too much detail, the bacteria will adhere to that, and then they create like a cocoon around. It's called glycocalyx, which will keep antibiotics or any other treatment from getting to it. So that's why we're really kind of OCD about implants such as total joints. Yes, ma'am.
I had a knee replacement 5 years ago. Am I going to need to continue taking antibiotics before every dental procedure from now on?
So her question was, she had a knee replacement 5 years ago. Does she need to continue that in perpetuity? The debate is in the literature. My recommendation, it's simple to take a couple of doses of antibiotics. I recommend all my patients go ahead and get prophylactic antibiotics, whether we prescribe it or the dental professional does. There's some literature says you can stop after 2 years, so it's surgeon preference, but our group is pretty liberal with continuing antibiotics. It's inexpensive, well-tolerated amoxicillin or penicillin. Yes, ma'am.
Can you talk a little bit about plantar fasciitis, and is there something to do? It comes and it goes, and it gets better, and it's done, and then it's
So her question was to talk a little bit more about plantar fasciitis, and kind of intermittent and inconsistent. So depending upon where you are in your treatment regimen, what you can do is you take a prophylactic stretching exercise, make sure you're in the right shoe wear. If you've done all that, it's just a matter of avoiding certain activities. You can say, well, when I wear certain shoes it happens, or when I dance for a long time it happens. It's activity avoidance. But usually prophylactic stretching and shoe wear. Great questions. Any more? Yes, sir.
Is ankle swelling an orthopedic problem or vascular problem?
Fantastic question. His question was, is ankle swelling a vascular issue or an orthopedic issue? So it can be both. With some of the slides that I showed you, the ligaments can be swollen, the joint can be swollen. That's more of an orthopedic issue, of course, a fracture. But it can coexist with a vascular issue. Using venous return or lymphatic return, everybody's, I'm sure, had a swollen foot from sitting too long on an airplane. So it can be both. The vascular could be, we didn't talk too much about it, it's a whole other topic, but the blood flow going through the foot can be compromised, or the blood flow going away. It can be as simple as just tight socks. So. Yes, sir.
You have a parent that says something about swelling your ankles and feet. Is that true?
So I think that is, his question was, if you take gabapentin, the literature in the pamphlet or in the box will say it could swell your feet. I don't see it that often, but it's what they've seen in their long-term studies with the drugs. That happened to you. I like you. You're a big, proud man wearing that jacket.
Well, man, Michigan.
Yes, ma'am.
Do you recommend supplements for just general joint health?
That's a question that's been asked a lot. Probably about 15 years ago, we were recommending glucosamine and chondroitin for everyone. We still don't oppose it, but we found that you have to take it consistently day in, day out for a lot of months. I just recommend a lot of good hydration, vitamin C, and patients our age, calcium and vitamin D supplements. But as far as like anything expensive, I wouldn't do that.
What about
Other questions?
anti-inflammatories?
What about anti-inflammatories?
Yeah, I mean,
So anti-inflammatories are a big part of our practice. It can range from over-the-counter things like Aleve and Advil, which is naproxen and ibuprofen, all the way to some of the newer generation oral anti-inflammatories, which is Celebrex and meloxicam. There's new topical anti-inflammatories that are out there that we use a lot. So the things you have to remember, and I'm sure you're aware of this, is it can irritate the kidneys, it can irritate the stomach, and it can affect platelets in the blood. So you have to kind of make sure, and that's a great thing about being with orthopedics, you get to look at the whole picture. each patient. I wouldn't mind giving that 18-year-old 10 days of Celebrex, but why not give somebody my age with a little bit of kidney issues? So. Great questions. All right. So, any questions? I've got a couple of other talks. This is actually a talk I gave to at a local meeting that the prison put on, but we may have some anatomy slides in this. Actually, go forward, see what's there. So really, I don't want to get into this too much because it's basically it's a talk I gave mainly for an athletic scenario when somebody comes in with a bad shoulder and it actually ends up not being a shoulder issue, it's a neck issue or whatnot. I thought I had some anatomy slides on there. So. Y'all want to talk some about the shoulder? You want to talk about other joints,
Yes.
or?
Yeah, shoulder's good.
Shoulder.
I apologize.
How long should you put up with what is the shoulder pains? I can't remember the word for it. Cheating.
All right, so let's do this. We'll go back to the front. We'll go over a couple of these cases. The anatomy's kind of mixed in. Bursitis?
Yeah. How long? I know you can't answer that question, but if you've had it for a couple of years, it's starting to taper off, but it's not now.
So the question was, how long do you put up with bursitis before you do something about it? Everybody's a little bit different. Most of the time, when they're in my office, they're not sleeping, and it's their dominant side. They can no longer put it. They have to get a ladder, get up on the cover. So if it's been going on 2 years, usually start off with X-rays, make sure there's not an arthritis or any kind of a spur or something that's causing it, and then the typical workup for bursitis. Old anti-inflammatories, home exercises, ultimately could potentially go to injections or work with the physical therapist. Very rarely for just plain bursitis you have to do something surgical. But to answer your question, is usually when somebody's not sleeping is when we get a visit. All right, so hopefully I can incorporate some of this. I was hesitant about talking about this when you said we were going to do some other things, but this was a talk about the esoteric things, the zebras. So this is a 49-year-old right-hand dominant female desk worker. You know, this is a sports-related talk. She was a mother of one of our varsity pole vaulters, non-smoker, non-diabetic. She reached back when she was playing volleyball, felt a pop. She rested, went to some physical therapy 3 months later, continued to have decreased range of motion. MRI was made to set possible frozen shoulder. She did have a temporary relief as home exercises continued. Is this the first of it, or is this the end? Okay. All right, so next slide. So 11 months later, her shoulder was on fire. And that's a key word for us to hear when something's on fire. Usually means nerve-oriented. Anti-inflammatories, muscle relaxers, even narcotics were not helping. Comprehensive evaluation of review systems was negative except some rib pain. All right, so that's patient number one. Patient number two is a 56-year-old referee, line judge. He's a diesel mechanic full-time. Had vague intermittent left shoulder pain for a couple of weeks. A little heavy, blood pressure high, but a non-smoker, social alcohol. At halftime, the trainer was asked to look at his left shoulder, and he was kind of aggravated by moving around as he was moving the down marker. Mid third quarter, patient, the referee ran into another player and clutched his left upper arm. Next slide. A 54-year-old healthy, active teacher woke up in horrible pain, on the 28th. 5 days later, went to urgent care. X-rays and MRI were negative. Given actually Tylenol, muscle relaxant, Tylenol 4, codeine, muscle relaxant, anti-inflammatory. 10 days after that, saw an orthopedist with constant pain, 7 out of 10. And the key thing was waking up at night. No fever, no other constitutional symptoms, no neck pain, no pain below the elbow, no numbness and tingling. Neck exam good, scapula had some decreased motion in the shoulder. Neck x-ray had some degeneration in the mid portion of the neck, and he was given a steroid pack. You like that? So this is the fourth patient. Is the fifth one on here, the new one here. So this is what almost made a change in my career. 15-year-old healthy JV football player with right shoulder pain after lifting weights and contact drills. Saw the athletic trainer, modalities reps, pain worsened, went to the ER, given a sling, referred to the team doctor. Office x-rays, MRIs were ordered, impingement and bone bruise, weakness developed, nerve tests were done, had a pinching of the nerve that supplies the rotator cuff. Second opinion with a shoulder subspecialist and musculoskeletal radiologist. Continued to have unrelenting pain, especially at night. He had a successful arthroscopic surgery and a nerve release, transient improvement. The physical therapist called and reported recurrence of pain and getting worse. And that same day he was evaluated by an operating surgeon and repeated x-ray. And the most recent patient we had is 82-year-old female, retired, married to two, never smoked, never drank, normal BMI, came to her primary care doctor with left shoulder pain, gave her some steroids, came to us because she wasn't getting any better. She had left-sided shoulder pain, shoulder blade pain, chronic neck pain, and poor views of her, or multiple views of her shoulder on x-ray, unremarkable cervical spine, had some age-related changes. We did do a subacromial injection, got an MRI, and she had a rotator cuff tear. She returned to us 3 weeks later. Pain was terrible, still was waiting to get her MRI approved by insurance. And the results were reviewed and it was actually negative. And so, yeah, we'll skip forward. I'll spare you all the talk about anatomy and things, but it's a good talking point when we support these 5 patients. So again, we talk about this because these are common. All 5 of these are common complaints you would see in a general orthopedic practice or a shoulder subspecialist. So the desk worker, as recollection, she rested. She went to therapy 3 months later. MRI was negative. Injection relieved her pain. She was ultimately diagnosed with primary embolus. So again, the whole talk is, think of the zebra. When you hear hoofbeats, think of the zebras, not only the horses. So the next patient, remember he was the line judge that ran into a football player during the game. He collapsed and required CPR, ALCS, had an MI, had a full recovery. Actually, he showed up at one of our playoff games a year later and was doing great. We went and saw him the next day in the hospital. He was stable. But probably if you're going to have a heart attack on a football field, you've got athletic trainers, AEDs, team physicians, and of course paramedics are right there. So he did well. But he was having acetyl antecedent to shoulder pain. So the teacher had all these medications, no other problems. All the exams were negative. She developed shingles. So that, remember we talked about the burning pain. We probably see that about, I'd say probably once every couple of months, depending on the time of year. So patient number 4, again, I almost quit medicine because of this. So we remember he banging around in practice just like normal, had his shoulder pain, got better, got worse, had the surgery, and the therapist called said he wasn't any better. Next slide. So all this did all the right things. I do have to say that when he showed back up that day, he had a lytic destructive expansile proximal humerus, which basically means his shoulder was eaten away. And next slide. So we sent him to an orthopedic oncologist, and he had an angiosarcoma. There were 6 in the country that year. 6. So angiosarcoma is just a back cancer. It's very vascular. That's why in the bone and all the tissues around it go through the bone. But you know, we were all just beating ourselves up. But we had all different radiologists look at it. Everybody had the same opinion. Sent them for second opinions, and so he ended up having a 4-quarter amputation. So he is now coaching middle school football in Flower Mountain. So great kid. The old adage is good, bad things happen to good people. And the most recent one that we added after this talk was this very active lady, had all the injections and things of that nature. MRI was negative in the shoulder, so you start thinking of the zebras. Ended up doing a CT scan of her chest and abdomen, and had some pancreatic cancer. Now she's doing great. She's having to go through all the therapy and treatment and things. So we've seen her around the hospital, and she's doing fantastic. So you think of bone, soft tissue, bone. You can have fractures, arthritis in the shoulder. You can have muscle, tendons, ligaments, depending on your age. So lots of things that can go wrong, but you always need to think of the zebras.
Why does it take so long to find out these things? I find that very hard in today's medical field.
Yes.
Because you experience all these, but sometimes it takes forever to find out there's something else underlying.
Exactly, and it's kind of a process of elimination almost. If you hear the key buzzwords, pain at night, rapid weight loss. Once we heard the burning pain, we started thinking, okay, maybe shingles. So it's a great question. I mean, sometimes the images, I tell patients images, even MRIs at this day and time, are not more than 90-92% accurate. So, but the point is, you got to look at the whole picture.
Are there some drivers, some big drivers that cause pain and joints that are not joint related? Like 5 or 6 primary big ones that you have.
You mean are there what causes the pain in non-arthritic issues or non?
Yeah, like maybe it's some liver enzyme floating around the body that causes joint pain. Is there like a grouping of 5 or 6 big ones that you see regularly?
So we always say that there's 5 sources, potential 5 sources of shoulder discomfort. Intrinsic, which is fractures, rotator cuff tears. The next most common is cervical, a nerve in the neck. That's the most common thing we see. And it's usually easy to discern after workup MRI. Then third on the list is, this doesn't really have to do with insides, we'll talk about that in a minute, but third on the list is any kind of nerve retractant. Any kind of nerve retractant. Carpal tunnel patients sometimes come in and they're having shoulder pain. And then by far the 4th and 5th, which we talked about here is viscerogenic. For example, you could have heart issues, you could have left shoulder pain, you could have liver issues, and right shoulder pain. The gallbladder is the most common. And then the last is neoplastic cancer of some sort. As far as enzymes, whenever a joint gets started on inflammation, the inflammatory cells, interleukins, things of that nature can go, they don't know what to do. They're trying to heal it. Hey, it's arthritic or it's hurt. We don't know what to do, so we're going to send cells there. And most of those inflammatory cells and that's what causes the pain. Any other questions?
On shoulders, my husband could be over here this right about impingement. What is the success rate in terms of significant mobility improvement for shoulder impingement surgery? He's had this for years.
So first, she asked, what's the success rate of shoulder impingement surgery long term? So let's assume you've gone through all the non-operative things. Most impingement without any rotator cuff tears or any damage, almost all impingement can be taken care of with injections, physical therapy, rest, activity modification. But if you do have to go to surgery, it's very predictable results. Typically, we find some scuffing of the rotator cuff or the biceps tendon, which goes right into the middle of the joint underneath the rotator cuff, and that's a cause of pain as well.
Right. And that and long-term prognosis for
Is excellent
surgery? Okay.
if it gets to surgery. So, go ahead.
Just a general question, do you find side effects from medications like metformin or statins and amplify joint pain?
Yes, she asked if there's any side effects from common medications that could cause joint pain. And the answer is yes. Some of the statins, especially early on, had a lot of joint pain problems. As far as other medications, it's individual. Some patients can take metformin and not have joint pain. Some people can not take it because it hurts. So,
Are there any over-the-counter helps for that, like the turmeric or the CoQ10 type of thing?
all the above. Turmeric is, I've had a lot of patients tell me that turmeric is good. As long as your system tolerates it. Of course, you know, all the anti-inflammatories we talked about earlier is good, but those have the side effects as well.
And is the CoQ10, is that helpful for some people?
Yes. Yes. And as long as if you take multiple medications, a lot of us over 60 do, as long as you're kind of aware of the interactions. For example, you wouldn't want to take a lot of fish oil if you're taking a blood thinner like Eliquis or Plavix or something like that. Yes.
Anything to do, easy to do for tendonitis without those unbearable shots?
Yes. So typically that's our second or third wave of treatment for tendonitis. And one, she asked if there's anything to do for tendonitis short of injections. If it's a true tendonitis, like Achilles tendonitis, things of that nature, we rarely want to do injections because it can weaken the tendon. Certain other areas, like bursitis in the shoulder, where it's a space, not one in the tendon, in your hand. So usually we start off with anti-inflammatories, some brace wear, home exercises or physical therapy. We can do ultrasound treatment, laser treatment is now available, and of course the anti-inflammatories we just talked about. Oh, I'm good. I was late, so I'm happy to answer your question. Yes, sir.
Will the Texas Rangers repeat?
Yes. But you're talking to somebody that has followed him since he was a
I've
little
been
boy.
in your office.